Thanks, everybody. This is great to be here today. I'm going to start our section on bowel disorders and start with Hirschsprung's disease and some of the problems we encounter as surgeons after the surgery has been completed. And as we all know, it's not as simple as just pulling out the bowel that has no ganglion cells. There are problems that persist in certain patients, and it's oftentimes hard to predict which patients are going to have trouble. So we will go through a process that's trying to evaluate how to take care of these patients. So the first patient that I'm going to present is an ex-35-weeker who did not pass stool in the first 48 hours. He had a suction rectal biopsy that confirmed Hirschsprung's on day of life 3, underwent an uncomplicated Suave-type laparoscopic assisted pull-through on the day of life 9, had a normal expected mid-sigmoid transition zone, and had 5 centimeters of proximal colon that was resected with normal ganglion cells and no hypertrophic nerve trunks during that procedure. He was discharged on day of life 26 and was doing okay before discharge. So the first question, and I'm not sure any of my questions have one right answer. I think there's a lot of opportunities that we as a group can come to help try to make these regimens more standardized. But the first question is, are there routine regimens that Hirschsprung's patients always get sent home on? Are there routine post-op dilatations, routine post-op irrigations, stimulant or osmotic laxatives, or you just send a patient home with no routine therapies and then treat them as problems arise, or is there another plan to treat them? I know I'll tell you what I do, and again, I'm not sure if there's any correct answer, and we'll see what the audience thinks. But I typically will send patients home, but see them back pretty quickly. Typically, as babies start stooling, there are no problems with stooling, but as the healing process goes on and there can have a narrowing of that anastomotic area, they sometimes can come back with stricture or an outlet obstruction type problem that just might need some dilatations. The baby stool at this age is often very liquidy, and so it doesn't help maintain that anastomosis that may be trying to narrow down in the normal healing process.
It looks like the poll results are coming in, and an overwhelming amount of folks are saying no home regimen. That's the most popular answer is nothing. And then shortly after that, it looks like there are some people who are saying rectal irrigations, and then daily anal dilations is the third most popular there.
And I think it may change. I personally will bring it back about 2 weeks or 2 weeks after surgery, and I'll calibrate the anus to make sure that anastomosis is okay. And as long as doesn't feel like there's a cicatrix or a narrowing there, you can decide what to do with the patient at that point. But again, very commonly, very early on, there's not problems. It's usually a little bit later, like we'll see in this patient, that problems start occurring in the young child.
I'll add in my 2 cents. I tend to also, probably along with based on the survey results, with the majority, that I don't do any routine therapies afterwards, especially initially, just because your anastomosis is healing. So any sort of insertion of either your finger or a dilator would have the risk of disrupting your anastomosis. And I really think that one of the reasons that there's probably not a standard method is because each patient is a little bit different. I think for all of us who are taking care of these patients, you have the realm of where you feel like you've done the exact same surgery on a patient, and some just do beautifully, and you think about 3 months later, what happened to that patient? They obviously have not come back to see me because they haven't had problems. And then the patient that's in your office every couple of weeks because you're not doing very well. And so I think it's very important to tailor your treatment for these patients to that individual patient and their results.
And that's a great point. So this patient, I did see him early on, and he did show some early signs of constipation. So we eventually did put him on some laxative stimulants on a daily basis. At one point, he was lost to follow-up for about a year, and he presented back with this x-ray. So at this point, he's about 2 years old. He comes in with fevers, an x-ray that looks like the one shown. So immediately in the ER, we did a digital rectal exam. He didn't have a stricture. We then did a barium enema, which didn't show a twist or an obstructing cuff. So we admitted him, placed him on IV fluids. We irrigated him. and we place them on IV antibiotics to help treat the apparent Hirschsprung's enterocolitis. So you've got this patient in your hospital now, and what are the next steps? Because it's obviously an obstructed post-op Hirschsprung's patient. And so we're going to work through how to handle this patient. So the next question is, do you just do a simple anal Botox injection? You know, you've shown that you don't have a mechanical obstruction from a surgery that maybe was done not perfectly. Do you divert him? He's got a very dilated colon on that left-hand side. Is it just time to give him an ostomy? Do you do a 4-quadrant rectal biopsy and anal Botox, a strip rectal biopsy and anal Botox? Do you just redo his pull-through at that time? Or do you treat his Hirschsprung's enterocolitis, let the inflammation get down, and come back and do some surgical options in the future? And again, I'm not sure there's any right answer. I think some action needs to be taken. But what will be the initial thought from the audience?
So for me, I would say that it would depend very much on how that patient has been doing recently or over the course of the time that he has pulled through. I think if the patient's been doing very well and this is the first episode of enterocolitis, I probably would be more likely to not intervene very much short of treating the enterocolitis and making sure he or she recovers appropriately from that. I think if this has become more of a chronic problem or recurrent enterocolitis, I'd be more worried about all the things that we worry about, an anatomic problem, a physiologic issue with dysmotility of the ganglionic segment, or something, technically wrong with the pull-through, such as a twist.
And Eunice and Megan, can you elaborate on what your management of enterocolitis is at your hospital? Do you have a fixed amount of NPO time? Do you start TPN? Do you do irrigations? How often?
Yeah, so at our hospital, we don't have a fixed NPO time, and we don't typically start TPN right away. We do start irrigations, usually about 10 cc's per kilo of normal saline every 8 hours to get at least for the first 24 to 40 hours and see how the patient responds. And we typically would start IV flagyl for the patients when they first come in.
Ours is similar, and I think one of the goals for us is to have a more structured protocol for treatment of enterocolitis, and ASHCO has been working a lot on that in terms of appropriately defining enterocolitis and then coming up with a standard management for that. But part of it is because it is a bit of a spectrum, because sometimes patients come in, they have a normal white count, they look distended, but they don't have any other signs of sepsis. And in those patients, we're more inclined to just start IV flagyl. For patients who have other signs of sepsis, we're more inclined to do broad spectrum antibiotic, add on top of gram-negative coverage. We tend to leave them NPO initially because they usually present with vomiting as a symptom. And then we're fairly aggressive about initial washouts 2 or 3 times a day until they clinically improve. And then really kind of oral start just is a clinical decision based on how the patient's looking.
And then the question is, do you send them home on standard flagyl therapy for a few months, or is it a single course? And these are all questions that are currently not answered, I don't think. So. And
do you send them home on irrigations if they've been admitted for enterocolitis?
I typically do. I don't think as a standard our hospitals, we're not even standardized here, but I typically do for at least a few weeks to try to make sure that they continue to have a good stooling process and they're not getting backed up again. But these are great opportunities.
I'm looking at the poll results, and it's interesting. So the vast majority don't really do much. It's about 46.7%. Now, if you take the two biopsy options together, they're both about 15% apiece. So they're a close second. I think that it was split pretty evenly until you started your discussion, and then it started to more people shied away from the biopsy. So one of the questions in the polling or in the chat room is about sending them home with probiotics. Do either of you use probiotics? And then the other question was, is there any role in this setting for anorectal manometry?
Those are great questions. In terms of probiotics, I think again, there's no standard way, and there's 8 of us here. We probably all give you 8 different answers, but I think the general trend is to use probiotics as a chronic management and less so as acute management of somebody with Hirschsprung's enterocolitis. In terms of anal rectal manometry, we do have that availability here, but we do it in the outpatient clinic setting, and so I find it a challenging diagnostic study to use on the very small child who may not be able to sit still for the appropriate measurements.
And for me, I think we may have 8 different ideas about how to use probiotics. If you just look at the probiotics in the market, none of them are standardized. So I think that adds another layer of non-standardization to probiotic therapy. So I think even if we are using them, we may not be using the same thing. So I think that there's kind of an unknown of how beneficial it is, but I do agree it's more of a chronic thing. And I think in this patient, with that dilated colon, I think manometry is very useful, and I think it is part of the paradigm. But in the situation where you have a very dilated colon, anal manometry, and even colonic manometry, the results may be varied because you have an actively dilated colon and it's not decompressed well enough to get good results. So after you've treated him now for the Hirschsprung's enterocolitis, I guess we've kind of gone into this. What do you do for him then? And we've talked about, I would send him home on Flagyl. I would send him home on some laxatives and probably some rectal irrigations just to keep them moving for some period of time. Is there anybody out there who wouldn't send them home on anything, or is that a choice from either a one-time Hirschsprung's enterocolitis presentation or this child who maybe has a more chronic problem because his colon is obviously very dilated on the left-hand side? My bias for this kid is he's for some reason one of those kids that dilates their colon. There are some kids who don't. This kid obviously does, so they're sending him home on nothing would just be expecting him to come back in the same situation a few months later. Something needs to be done more for this child.
Yeah, I agree with Megan. I think that so one of the components for me as I think about patients I care for with Hirschsprung's is how to equip the parents appropriately to be able to handle problems at home. And so I think irrigations is one of those things that it's a tool that you have to teach them. If you feel like this patient is going to be somebody who is likely to have some level of recurrence of this problem. And so I think one of the challenges for a lot of families are just when do they show up to the emergency room? When is their constipation bad enough to show up to the emergency room? And if you appropriately teach the parents how to do a washout and give them the tools to do so, it just allows them to have a little bit more freedom that they could do that initial washout if they see their child getting sick. And I think it improves their quality of life at home.
That's a good point. I think that's very important. But we here have recently come up with a very standardized teaching regimen for our different campuses. We also have found that there was a lot of education that needs to be done on the floor while they are inpatients. And because this is not a everyday common occurrence, the nursing staff very commonly will have a different level of education based on rectal irrigations, rectal enemas. And so we do have a regular education process that we do to the floor nurses to make sure they understand what a rectal irrigation is and why it's important. And we also have come up with a standardized order form now, so that it's much more clear for the nurses about types of tubes, how it's supposed to be done with links to policy. So it's an education for parental needs, but also education for in-hospital to make sure the care is delivered as you expect in the hospital as well.
Hey, Megan or Eunice, let me ask you a question. As I was interested as y'all were talking, is there any evidence for anything that y'all have mentioned? I mean, it seems like this is a ripe topic to try to get some better evidence for it. But I'm just interested to know, is there evidence for what y'all are, for any of these suggested treatments?
No, that's why I don't think there's any right answer in these. And I'm hoping that we can come to some better plans and recommendations for us. But I think we're at the beginning stages of kind of coordinating what is, just like Eunice mentioned, what is Hirschsprung's enterocolitis, and coming up with scores to make sure we diagnose it correctly. And then, as I'll show some pathways of how do you work these patients up. If we're not working them up the same way or treating them the same way, it's really hard to draw conclusions. So I think you're right. There's not a lot of data, but there's a lot of opportunity to try to come up with that in the future.
And I think that's something, you know, for those who are interested, the APSA Hirschsprung's interest group is working on that. Like Megan said, I think defining enterocolitis, if we could do it appropriately, allows us to actually have better data on outcomes, and we don't define it well. So in all the retrospective studies, the appropriate management and outcomes are all over the place, because, you know, somebody coming in with constipation, you may categorize as enterocolitis and put them on Flagyl, but that's really not the same patient that comes in hypotensive, tachycardic, with an elevated white count. And so to be able to appropriately risk stratify patients initially is useful. And so, yeah, I mean, the idea of what you should send these patients home with in terms of length of therapy, both on washouts and on antibiotics, is relatively undefined.
So this is one guideline that's come up. Dr. Langer published this with APSA Hirschsprung's disease research interest group. And it just looks like for the child who has Hirschsprung's, who's obstructed postoperatively, how do you work them through? And so the first thing is what we've kind of outlined. You examine them, you make sure there's not a mechanical obstruction. You then proceed on to rectal biopsy if there's no mechanical obstruction, but the signs of obstruction still persist. You're either going to find that you had a good procedure done before that has no significant pathology, and then you move on to trying to treat their obstructive symptoms with we all know that with an absent rare, they're going to have somewhat of an outlet obstruction at their anus. And so the Botox has been very helpful to try to overcome some of that intense contraction of the anal sphincter. Problem with the kids that are the ones who don't improve very well, and those you do move on to motility workup, whether it's SITS markers for a transit, or you do formal motility studies with both an anorectal manometry to see if they're withholding, or if they have a functional area of their colon that maybe isn't working well, that needs to be resected because it's acting as a common cavity and it's just not letting the normal progression of stool passage occur. And then there's also the children who then are still having some difficulty, and then you move on to a bowel management with either a stoma, which is usually not the family's first choice, or an antegrade continence catheter or procedure that allows you to wash antegrade enemas in a antegrade fashion. I do have to say, you know, the Hirschsprung's kids are a little more difficult than the anorectal malformation kids because they do have an intact sphincter, and that outlet obstruction at their anus sometimes is very difficult to manage even with an ACE. But it can be done, and this is the next step for those kids who are acting obstructed. So I think this kind of thing is the first step to trying to study kids long-term to make sure we're all doing the same thing at the beginning. I have one other patient that we'll talk about, and this is probably more difficult. The babies that are obstructed show up when they're a few months old to a couple years old, because if they're not passing stool, it's a very easy sign for parents to see. This child had the opposite. He's hypermodal. He's having fecal incontinence with Hirschsprung's disease. And those kids often present a little bit later, not because anything's occurred, but early on in life, if patients are all in diapers and they're stooling in diapers, then stooling too much may be missed. It's not until they get into kindergarten or school age when the fecal soiling becomes more of an identified problem. So this child had Hirschsprung's disease diagnosed as a newborn. He was treated in an outside facility. He had a pull through on day of life 3, normal transition zone in the descending colon. He went to kindergarten and then was quickly withdrawn because he was having so much fecal soiling. He has 2 older siblings and they both were in school, but he needed to be homeschooled due to his fecal soiling. So he had an ACE procedure performed at 7 years of age. He then relocated to Atlanta and came to our outpatient clinic, and he was soiling. He was at that time getting 100 cc's of normal saline and some Castile soap flushed through his ACE tube, but he was soiling 5 to 6 times a day, not just smears, but full bowel movements. Very normal kid, very active, very intelligent, but just needed to change his clothes a couple times a day, and that just wasn't allowing him to function in society where he should have been at his age. So if he's in clinic with you, what do you do for this kid? With that story you have, there's not much you can do while you're actually in clinic. But so what do you tell the family on that first clinic visit? What do you send them home with? What is the next step? And we'll go on to surgical stuff as well, but what do you do for them while you're there? Do you increase his flush volume because 100 cc's for a 9-year-old is pretty small? Do you add glycerin to try to evacuate a little bit better? Do you just try to stop him up now with antidiarrheals? Do you give him laxatives? Do you give fiber? Do you add him a constipating diet? Again, very many options. Not sure if there's any right answer, but any thoughts about what the next step would be?
I would say, since
Megan?
we're running about
Yeah,
40 minutes behind, so why don't we just skip through, just get a quick answer and we'll do rapid fire for these.
So obviously we need to slow him down. So we slowed him down a little bit, and then we went on to the operating room to try to figure out what the problem is. And this child, his issues potentially was the opposite of the other kid. Did somebody injure his sphincters and his outlet is not working? Can he not sense things? Or does he have a motility problem where he's just not able to control what's coming down? And for this child himself, we went exam under anesthesia, intact sphincters. He had an intact dentate line, went on to manometry studies, but he had HAPC. So he had these high amplitude contractions that were pressures upwards of 400 millimeters of mercury all the way down to his anus. And I don't think anybody can control that type of pressure coming down to your anus. You know, as a newborn with Hirschsprung's, his capacitance organ, his rectum was removed. So now he just had these high flow pressures coming down to his anus, and he just wasn't able to physically control them. So in this chart that was published by PIAM, he would be considered to have pseudoincontinence, hypermotility, and we did all the things listed here. And we constipated him with diet, cholestyramine, Imodium, and we still then used his Chate tube, and we had to move to twice a day irrigations in addition to 24 milligrams of Imodium a day, 27 grams of fiber, and cholestyramine. And we finally got him back in school after about a year, but it took about a year to try to figure out his system because everybody's system is a little bit different. And not one thing works for every single child.
That's great, Megan. There's a lot of great questions being asked in the chat room. I know we're running behind, like Todd was saying. We're going to try to get through these cases really quickly. So hopefully you, Beth, and Eunice will have time to answer some of the questions in the chat room as well. Great.
Thanks.
now I think Eunice has a case. Or are we going to Beth?
Yeah, I'm sharing a case. So I'm going to talk a little bit about rectal prolapse. This is a relatively unusual problem, but we recently had 2 systematic reviews that came out, and so thought it was worthwhile kind of discussing this. I'm going to just start with a quick case presentation. 3.5-year-old male presents with an episodic rectal prolapse, has had several episodes of circumferential prolapse that spontaneously reduced, but then recently the prolapse required manual reduction in the emergency room, which was what prompted the mother to seek further evaluation. So how would you manage this patient? So I'm going to allow people to, so we'll talk a little bit about this. So probably the most common time we see prolapse are when kids are in their potty training phase. So I think it's not common for surgeons to really specifically be involved in these patients. Are you seeing responses? And any comments on that?
I'm not seeing responses right now. I think we're having some people with some technical difficulties. Go ahead and type in the chat if you guys have thought. Oh, it's popping up now. Here we go. So go ahead and answer the poll. But before we get to those answers, I mean, how about some of the moderators here? What do you guys think? What's on your mind here?
I think this is like a nightmare in clinic. Honestly, this is the patient that no one wants to see, right? I mean, rectal prolapse it's very distressing to the patient and the family, and we don't really have a lot of great options. So if it's a patient that I've never met before, I typically will address, concerns about the constipation first and sort of prove or disprove whether or not this patient is significantly constipated. I think if they are constipated, that's like the easier patient to deal with, but every once in a while you get a kid who is well managed on whatever their regimen is and they're still prolapsing. And then I think the question is, what do you do? And if someone has the answer, I would love love to learn it.
So that's great point. So what, so sorry, my computer decided not to work with me here. So I think the key to this, we'll just quickly just to go through, most prolapse are not in need of surgical management. They do occur most commonly in potty training age. They usually come from other medical issues such as constipation, just sitting on the toilet incorrectly within a squatting position as opposed to a sitting position. It happens in kids because of the anatomy of children. They have a very weak pelvic floor and the rectum is very low, and so it tends to pop out easily if you strain hard enough. The things that's important to sort out are other medical diseases such as polyps, parasites. Definitely cystic fibrosis is something we should think about when we see these patients in our clinics. And then, of course, Hirschsprung's patients and anorectal malformation patients, that's a subpopulation of people that if you define those people, their management may be a little bit different from this population we're going to talk about. You need to differentiate them from polyps versus intussusception and hemorrhoids and such. So the physical exam is quite important. And then, of course, management, since they most commonly are from medical issues, if you treat their constipation and teach them how to sit appropriately in the potty. So sometimes that actually entails getting them a smaller seat so they're not falling through the toilet, and then also giving them a step so that they're sitting properly upright and that they don't spend a lot of time on it. They're not getting an iPad where they're sitting there for half an hour straining. And so most commonly, this could be managed just by medical therapy. You should always teach the parents how to reduce the prolapse, because it certainly, like Beth said, it's kind of stressful to see that in your child. And then so such that they could kind of it doesn't get incarcerated just from prolonged sort of just being out for a long period of time. And then it's also helpful for them to take a picture for you so you can make sure that it really is prolapse as opposed to something else. So what if you have a patient, as Beth was talking about, who has been appropriately managed, there's no other medical issues associated with them, and then they have persistent problems. So let's take a 10-year-old female who presents with chronic recurrent rectal prolapse despite medical therapy for constipation. So what would be the next best option for management? Curious to hear from the panel of experts.
I've got a low threshold for starting with sclerotherapy because it's simple, it's innocuous, and then sometimes they just need that head start, particularly in that last case with the younger kid. They just need that window of a couple of months to not have a prolapse, and then they start seeing it less frequently.
Okay. Do you have
Suture decal.
Sean, could you describe your technique for that and what you use?
Yeah, 5 cc's of Suture decal and injected in 4 quadrants, and then if there's a little left in between.
Does anyone else have trouble getting the sclerosing agent approved in their hospital? Because I can't get anything. They have safety concerns about hypertonic saline. A lot of the other mixtures are actually not technically sterile. They're not made from completely sterile components. So I've had a lot of issues actually even being able to do this at all.
So, you know, I have a lower threshold, I think, than some others for a suture rectopexy. And, you know, if you look at the adult literature, if you do a suture rectopexy, you know, the sclerotherapy doesn't work that well. I've not had a lot of great success for sclerotherapy. Again, like you said, you know, Sean, it's easy. If you have them, you're doing an EUA, you can just go ahead and do it then. But I have not had a lot of success for that, especially with a patient that's like chronic and recurrent. And
yeah, the 10-year-old here is a little bit of a different story. When I say a low threshold for starting with that, it's usually 2 strikes and you're out. That after 2 rounds, then I would do a laparoscopic rectopexy.
Yeah, and the real question is whether you do a sigmoid resection with that or not. And I do it based on what the enema looks like, if there's a big redundant sigmoid. But in the adult literature suggests that a sigmoid colectomy should be part of that, but I don't know if we're treating the same disease process.
Hey, Rod, can you go through and rapid fire read? Because the audience has been pretty active with this.
Yeah.
Yeah, absolutely. You're right. We do have a lot of stuff going on in the chat here. And there are some people who kind of like what we alluded to is talking about toilet positioning and kind of these non-procedural measures first. There's some talk about some people have access to different resources. Some people have people who are experts in pelvic physiology, and they can work with these kids at their centers. And then some people are having results with dextrosclerotherapy as well. D50, hypertonic saline. There's a lot of things here. We have a couple questions that, another question I wanted to say here, deflux can be used in the prolapse, question mark. And then also about repeat sclerotherapy. So maybe how many times are we doing this?
So I'm glad everybody brought that up. So this kind of brings up, and I love the fact that everybody talked about different methods, and there are a lot of different options out there. So secondary surgical management, injection sclerotherapy is very popular. There are perineal approaches to doing a rectopexy or a rectal resection, whether that be mucosa or full thickness. There are open and closed methods, depending on how you tack your rectopexy. There's abdominal approaches, the laparoscopic pexy, rectopexy is very popular. So recently there was a systematic review that came out that looked at a conglomeration of publications. And so a couple things I wanted to point out. There were 27 publications included. And it spanned, obviously across the whole world in terms of all these publications. There was, out of these 900 patients, 300 of them were about sclerotherapy. And so you notice this, there were 8 studies and only 3 sclerosing agents involved. In the 600 patients that underwent operative management, there were 22 studies and 17 procedures. So anytime you see that large volume of procedures, you know that we're not exactly sure which is the best procedure for this pathology. So, so if you look at in terms of actually operative procedures for this, there are many different options, but they do have some fairly high success rate. And to Mark's point about the transabdominal procedures, what has been published have shown that they have pretty high success rate of being correcting the prolapse. So, so then the second point, the second question is, if you are going to utilize sclerotherapy agent, which would you use? So I'm going to move on to the next slide for the sake of time. So there was a second publication also in JPS from 2019 that looked at just a review of publications on sclerotherapy for rectal prolapse in children. And again, there are 19 studies, and if you look at the studies, most of them actually were not from Northern America. The mean age of kids who underwent sclerotherapy was 4 years old, which surprised me a little bit because it did seem younger than in my experience. And then there are multiple different sclerosing agents, and probably the most commonly used is alcohol. And I had the same issue as Beth when we were historically we've used phenol. However, that's not a product that we could use anymore to inject into a patient, and so I switched over to alcohol because of that reason. Success rate is very high, so this number was very useful to me, and that speaks to what Sean was talking about, that your initial success rate is high. But if you fail the first injection, you certainly could give another one, and that will increase your cumulative success rate. And so you max out about 80, a little bit more than 80%. So once you're to the third and it's still not successful, it's probably reasonable to proceed to an operative intervention such as the laparoscopic rectopexy. So I think that in this day and age, probably most people use alcohol, 95% alcohol, because the success rate is high. It's something that you could obtain in the hospital because your interventional radiologist probably, or your vascular anomalies clinic probably utilizes that product on a regular basis for sclerotherapy anyhow. And then the best part about using sclerotherapy as an initial procedure is that the complication rate is really mostly negligible, and they're acute, and there's not really any, there's a very minimal risk of long-term problems with sclerotherapy. And so with those two publications, this is sort of the algorithm that should be considered. And part of this was actually published in the discussion component of the Morrison paper. So if you have a patient with rectal prolapse, you should rule out underlying diseases, especially cystic fibrosis. You should make sure that it is a rectal prolapse and not a polyp or hemorrhoid or something else. If it's a small child that is in the potty training phase, certainly having appropriate management, medical management of how you do potty training is appropriate, and then make sure they're not constipated and treat that appropriately. If that fails, then sclerotherapy is probably the best first therapy because it's relatively effective with minimal risk of complications. And if it fails within all the open operative management or operative management options, laparoscopic rectopexy is probably the one with the highest success rate with the lowest risk of complications. And so that's the recommended first procedure operatively. All right, I'm going to just talk about something that somebody else also brought up, which is the benefit of having your pelvic floor therapist, pelvic floor rehab program also involved in care. And I thought this was a great paper because partially I had a patient that was 10 years old that was sort of in this category. And I was glad to find that there was some support in the literature that this is the way to manage them. So 12-year-old male presents with chronic recurrent rectal prolapse refractory to medical therapy. He's seeing you for consideration of surgical treatment. He has also been diagnosed with depression and anxiety, which are being treated with medications. What should you inform his parents about this? Is he not a candidate because he has a psychiatric disorder? Is he likely to have a lower rate, higher rate of recurrence because he has a psychiatric disorder? Or would he benefit from multidisciplinary care? And so, shall I just go on since for the sake of time, Todd? Yeah, okay.
I would,
right.
yeah, but it looks like so far everyone is answering, well, it's changing a little bit, but most people are answering the last choice.
Okay. And that really would be appropriate. And really, in my experience, that's been very helpful. So in this patient population, this patient this publication came out of Michigan, and it was based on their experience as they were caring for patients with rectal prolapse. And they realized that they were having a lot of patients on especially in the older population that were not isolated rectal prolapse, but they also had other psychiatric diagnoses such as obsessive compulsive disorder, anxiety, depression. And so the question was whether they would have, they would be more refractory to any surgical management that you had to offer them. So in their patient population, for those who are greater than 3 years old, about half of those patients had a secondary diagnosis in addition to the rectal prolapse. And they did have reasonable success rate utilizing sclerotherapy mostly for these patient population. But for those patient population, they also refer them to pelvic floor rehab concurrently so that they were being managed. Both they were getting optimization of management of their psychiatric disorder, as well as behavioral modification with pelvic floor rehabilitation. And then in addition to that, their surgical management. And in my experience, that has been very effective because partially it's a feedback loop. So they are anxious and they have rectal prolapse, and it becomes this sort of, for one of my patients, it was sort of an emotional release for her to actually prolapse herself and evacuate stool. And so it was important that in addition to sclerotherapy, I was able to help her support her through the anxiety component of that. And the pelvic floor therapy was very useful in strengthening the pelvic floor musculature such that once you perform the sclerotherapy, then they're likely to have a more durable outcome from that procedure.
All right, that's awesome. So I obviously a frustrating problem that all of us see, and I've been anxious for you to present this. So I appreciate you presenting this, and this was another good summary that we'll be pushing out for people. Eunice, that's all your cases, right? You and Megan are, okay. So we wanted to invite Beth Rymeski back again. We invited her last year and then changed the time on her, and she had cases. She's one of the busiest surgeons, so it's always hard to grab her. But we got her here, and she's going to present something that I asked her to present last year because it blew my mind because I had never heard of something like this and everyone else had already heard of it. So there you go again, I'm behind the times. And I've been using it since I was taught about this. So Beth, take it away.
So I'm going to talk about adhesive small bowel obstruction specifically in regards to using Gastrografin as both diagnostic and therapeutic management. So the first patient, while not a child, is probably a patient that a lot of us still are dealing with in our hospitals, if yours is anything like ours, where we have a 29-year-old male who comes to the ER with 24 hours history of distension and feeding intolerance. He is a neurologically devastated patient with syndrome and HAE. He's trached. He has a lot of issues, including autonomic instability, and he's had multiple admissions in the past for small bowel obstruction. This is his surgical history. When he was very young, he had a duodenojejunectomy as a bypass for SMA syndrome. He had an open Nissen G-tube. He had an XLAP for a bowel obstruction 7 years ago. He had an XLAP for a bowel obstruction 6 years ago, which included an ileocectomy at that time. And then 4 years ago, he had another XLAP for a bowel obstruction. And at that time, to facilitate care and based on massive colonic distension, he got an end colostomy. So this is his presenting x-ray. This is just, this is the supine view, I believe, of the most recent presentation. Labs are, a little bit out of whack. Sodium's a little low, chloride's a little low. His baseline creatinine is 0.2, but he's 0.99 today. His CBC looks fairly hemoconcentrated. So what would people do next?
So do we have choices?
There should be a poll popping up, I hope.
Yeah, there it is.
Oh, there we go. So would you do an NG tube and G tube decompression, fluid resuscitate, and do serial exams? Would you send this patient for a CAT scan based on these images? Would you resuscitate this patient and take him to the operating room? Or would you do NG and G tube decompression, fluid resuscitate, and give a Gastrografin challenge?
So Beth, we're gonna wait about 10 seconds. Let me ask the faculty while we're waiting here. Mark, and I know what happens in Cincinnati, so let's ask people from other places. So Wolcan, anyone, Sean, Liz, Bob, Eric, what do you guys do? Eunice? What would you do for a bowel obstruction? How do you manage a bowel obstruction?
Yeah, I mean, at first we just tried decompression and probably sit on them overnight and see what happens. And then, the question, we would use Gastrografin. We might get it, if it's not really that much better, we might even probably just do a CT scan with Gastrografin. So then you can find out.
Gastrografin. Liz, do you guys use Gastrografin?
So we would resuscitate this child, decompress this child, do serial exams and a follow-up x-ray. And if it did not look like it was improved, we do a CAT scan.
All right, rapid fire. Let's see who else is unmuted. Eunice.
Yeah, I think that the key initially is identify whether you think this is high risk for a complete obstruction versus not. So if you think it's partial, then you could bowel rest. And then I think that patient population for us, we would consider Gastrografin once you're fully resuscitated. So certainly not the first day. But if you're concerned that it is closed loop obstruction, we may either get a CT scan to confirm that or just go straight to the operating room.
Okay, so I'm not going to go through everyone. Is there anyone that disagrees with what Eunice just said?
I'll just raise my standard thing that I always raise, which is, why are we getting a CAT scan?
Why are we getting
Beth is laughing.
I've heard this talk before.
Okay, go ahead, Beth.
Okay, so this patient, we did use our Gastrografin protocol on him. His abdominal exam, while distended, was not concerning for peritonitis. So I'll show you the protocol at the end, but it's a pretty standard Gastrografin protocol where we administer through either the NG or the G tube and then clamp the tubes. Try to leave them clamped until the first x-ray, which is between 8 and 10 hours, and then go from there. So in this patient, the first x-ray here on the far left of the screen, you can see that there's still contrast sitting in dilated loops of bowel, but the arrow here pointing to this looks like it's in the colon, but in this sort of twisty spine patient, we weren't 100% sure. So we got an additional one which confirmed that. You can see that the contrast has passed through, and this is actually his stoma bag, because this is a patient that, remember, has a colostomy. And then on the 24-hour x-ray, essentially all of the contrast was gone with a small amount of residual here in the colon.
All right, so
and then go
yeah.
ahead.
No, Miguel, in a second, I'm going to want you to open your mic and chime in because I see what you wrote in the chat. Keep going, Beth.
So what this allowed us to do was then to, sort of get rid of the NG tube and work towards resuming feedings in this patient, since he, clearly did not have a true bowel obstruction.
All right, Miguel, what do you got to say?
No, I just involved that we need to be sure at some point that this only includes only a mechanical obstruction and there's no any ischemic involved with this obstruction. Even if it's pseudo obstruction or an incomplete obstruction, we can be confident that there's no ischemia in this thing. We can do that whatever we want. We have the time, but we need to be sure about that. So at some point, maybe the CAT scan with an angio scan could be very important, or a Doppler maybe sometimes.
So I think in our experience, we've just relied on, x-rays and physical exams. So as part of our protocol, it is an absolute requirement that the patient be examined by the attending surgeon before this is enacted. And they also have to review the x-rays, because we did have some rogue behavior at the beginning where people were saying yes, but not actually seeing the patient. So I think that's kind of a safety measure that we've implemented to try to decrease. You don't want to give a Gastrografin to a patient with peritonitis.
Okay, so Jay, can you go to the Zoom view so we see all the faculty, put them all on the spot here? Go to the Zoom view for a second. Tell me when we're there, because I won't know when.
There.
Okay, raise your hand if you get CAT scans routinely on bowel obstructions. Raise your hand. So I can't see everyone. I'm guessing I'm the only one raising my hand. I think. Let's see. We'll see what everyone did.
I am not raising my hand.
I know. I think I'm the only one.
St. Peter's also raised his hand.
Me and Sean, and Sean's really smart. So that puts
always
Megan
in
raised
any
her
case.
I hear Megan raised her hand as well.
Hey, Todd,
But
are
not
you
always.
are you asking if the staff get them or the fellows get them?
I'm actually asking if they asked you, would you tell them to get a CAT scan?
I'm not sure they'd ever ask us.
All right, let's keep going. Sorry, Beth.
Okay.
No, that's okay. So, anyone who works with residents probably knows that this is pretty much the standard of care in adult surgery now. And a lot of us sort of learned this protocol by discussion with the residents. And it was one of our residents that really kind of pushed us to start doing this a couple of years ago and said, I don't understand what's wrong with you guys. Why are you not using Gastrografin for bowel obstructions? There's less data out there in pediatric patients, but what limited data there is does seem to parallel the adult data in terms of both safety and efficacy. I believe Jay, somewhere in the Global Cast world, has some references for some articles if you're interested in reading them. It's not on the slides. So this is our protocol, which is adopted from multiple sources and sort of just made more specific for what we want to do. But it categorizes patients by age. Some people do it by weight. And essentially it's a diluted Gastrografin that's given. We need, like we said, there should be no signs of strangulation, peritonitis, if they have active malignancy, and it has to be an adhesive bowel obstruction. So this is not for a patient who's never had abdominal surgery. We do NG tube decompression for at least an hour. It's often longer than that. Confirmed by x-ray that the NG tube is where we think it is. The surgical team then administers the Gastrografin and clamps the tube. Obviously, if the patient can't tolerate it at any point during that, we unclamp and place it back to suction. But if they can tolerate it, we leave it clamped and get another x-ray at 8 to 10 hours. If the contrast at 8 to 10 hours is already in or past the cecum, then you're basically done. You've prove them that there's no bowel obstruction, you can take out the NG tube and start feeding the patient. If at 10 hours it's not in the cecum, then you get an x-ray at 24 hours. If it's in the cecum, then you've passed and you take out the NG tube. And if it hasn't, you can much more rapidly move to the operating room than maybe if you were sitting on this patient and just doing NG tube decompression and waiting for 2-3 days to see if it resolved. So this is our protocol. There are others out there. And this is also included in the attachments if anyone's interested in looking at this. My case obviously was an adult. A lot of us see these adult patients, but it does work in kids. Here's this picture on the left is a 7-year-old with a history of a perforated appendicitis who came in with an x-ray looking like bowel obstruction and had a successful Gastrografin challenge seen in the other screen. And it doesn't always work. This is a 3-year-old with history of gastroschisis. This is her initial x-ray, lots of dilated loops. There's also a lot of poop down in her rectum and distal colon. At 8 to 10 hours, there was contrast throughout multiple dilated loops of small bowel. And at 24, the same. So she was taken to the operating room and found to have dense bands across the base of the mesentery, which required surgery. You know, her belly exam was stable and benign throughout this. So I think that's all for my slides, and interested in any further discussion.
I love that case. And by the way, for those of you who didn't take a screenshot when Beth put that algorithm up there, we do have that guideline, I think, in the Stay Current app. I'm pretty sure, Beth, I'm not positive.
Yes, but it is in the Stay Current app, and it'll be an attachment on the GlobalCast. One of the poll questions was just asking, has any, like, of the people participating virtually, have people used this, yes or no, or have they just never heard of this?
Yeah, so so Rod, go ahead.
No, I was just gonna say, if anyone's having trouble, we're also tweeting that slide out with the flow chart there.
Right, and so Beth, the answer is that most people, the percent is 53% have used it. A small percentage, 12% have never heard of it. So at least people have heard of it. That's a huge step. And then what about now? So let's see, now it says after seeing this presentation, there's still some holdouts that you didn't convince enough people, Beth. So, you know, you got to sing and dance next time or whatever it takes.
Hey, we'll have to work on it.
I'm so glad we got you to do this talk because it's been game changing for me. I think I have my partners on here in Akron because I work at Cincinnati and Akron, but I think when I learned it there, I started doing it in Akron, and I know Bob Perry's on here, and I think he had a not so good experience with it, but I want to hear if he comments on that. So yes, it is on Twitter. I'm reading the comments there. So thank you for that.